Welcome to today's webinar, From Data to Breakthrough, Addressing the Root Causes of Medication Errors. I'm Stan Postotnik, and I'll be the moderator for this webinar. It's my pleasure to introduce Dr. Brian Parrish and Dr. Luma Secor, who are the co-founders of Salus, a medical software and device company dedicated to enhancing patient safety through innovative solutions. They are also the co-inventors of MAPS, the Medication Administration Protection System. Dr. Parrish will be the primary presenter, and he is a seasoned cardiology pharmacotherapist with over 20 years of experience specializing in electrophysiology, interventional cardiology, and advanced heart failure. Dr. Luma Secor will be participating in the Q&A. Dr. Secor is a board-certified critical care pharmacist with nearly a decade of experience at Houston Methodist Hospital, where she currently serves as the clinical specialist leader in the surgical and liver ICU. Brian, take it away.
Great. Thank you, Stan, for that fantastic introduction. And thank you all for attending. Excited to have you as we begin a series of webinars that are going to be focused on really uncovering, definitely starting today, addressing the roots of medication errors, how much of a burden they are in our healthcare environment, as well as where the literature lies, what has been done so far to try and combat these problems, and then starting to move forward to new solutions that we actually offer at Salus that we hope will absolutely eradicate medication errors and make them a thing of the past. So we're going to jump right in, and I'll start off by giving some introduction over some background literature wrapped around how big of a burden and how deadly medication errors are. We're going to go through some pain points and solutions that have been offered thus far. Throughout this talk, you're going to see me jump in and out of a patient case that's really going to magnify where these problems are occurring when we address the roots. And then we'll get some conclusions and takeaways and offer some time for you all for some Q&A. So it's a pleasure and an honor to have you all here. So let's start with this patient case. Pretty simple case, actually. It's a 78-year-old female with a relevant medication history of hypertension, type 2 diabetes mellitus, osteoarthritis, primarily of the knees and hands, chronic kidney disease stage 3 with the baseline GFR around 45 mLs per minute. The key pre-admission medications are lisinopril, metformin, glipizide, amlodipine, naproxen, and atorvastatin. So the reason for the current hospital admission will be the patient will be admitted due to a severe flare-up of osteoarthritis pain in her right knee. The treatment goal will be the obvious. Let's control her pain and investigate further if anything is needed. Based on her initial profile, now I'm going to ask some questions, and really based on the format, these will be more hypothetical in nature. Feel free to offer an answer in the chat if you would like, but it's really just to get your minds thinking in the right direction. But based on this patient case and based on her profile, her age, chronic kidney disease, stage 3, her current medication list, what are your immediate concerns as you process this if new medications, especially for acute pain, are to be prescribed? Are you worried about 1, polypharmacy and increased risk of drug interactions? 2, the impact of new drugs on her kidney function. 3, appropriate pain medication choices for the elderly with CKD. 4, bleeding risk with certain pain medications, or all the above. So let's dive into a little bit of background on medication errors. Some of you on the call are probably seasoned veterans in medication error space and medication safety space. So this may be not news to you, but there's others that may not be. The main thing to drive home here, and that what we're trying to promote and teach everyone around the world, is that the true pandemic that we're dealing with here are medical errors. It is the third leading cause of death in the U.S. When this literature was released around 2016, 2017 from Johns Hopkins, it really magnified how big of a problem we're dealing with. The article is very interesting, but Dr. Mark Reed talked about how we don't have ICD-10 codes to classify a medical error as a cause of death. So a lot of these deaths are being labeled as cardiovascular in nature from cardiovascular collapse or sudden cardiac death due to the actual error that was caused. Medication error is the most common type of error, and honestly, they're preventable. We all know it. We've been practicing for a minute, and we see them occur at all stages. all stages from admission to discharge, and even as an outpatient in prescribing, dispensing, administration, and monitoring. The burden is overwhelming. We know that they're deadly, but they're also costly. Yet 1.5 million preventable adverse drug events that are occurring per year, an incredible amount of morbidity and mortality wrapped around this in the U.S. alone. So let's not forget the economic burden. It's over $21 billion a year, and that is a very conservative figure out there. And the risk of litigation and regulatory penalties are also an incredible burden, and not to mention that there's been criminal lawsuits and so forth that are wrapped around this as well. So there's a really big magnifying glass on this. It's an incredible financial burden, a very deadly problem, and really is what we're trying to accomplish here is eradicating this issue. So let's turn back to the patient case now. When the patient was seen, a decision was made to start ketorolac 15 milligrams IV every 6 hours for the knee pain and get rid of the naproxen. From a system note, CPOE systems has that basic allergy, drug allergy checking, but advanced clinical decision support modules within that space are really lacking. From a pharmacy administration standpoint, this medication gets to the pharmacy, unfortunately, due to things like limitations, alert fatigue, same with physician order entry side of things. The drug gets through, it gets verified. And now knowing what we know about the patient, we can start asking ourselves questions. CKD stage 3, concurrent use of lisinopril, what potential problems might this ketorolac order pose for this patient? And two, ideally, what should have happened at the point of order entry? Should we even be at this point? What could have been done differently? Reporting of errors have historically been a real issue, and there's a number of reasons. Underreporting, it's been known to happen. We've had this issue for some time. Definitely voluntary reporting has increased of late because there's a lot more support. And that brings us to the barriers. Fear of punishment has been a big issue wrapped around this. The event recognition, is this really an error? Is it not? The time constraints wrapped around it, how long it takes to fill out a medication error report. The fix and forget mentality, which is where I fall into play a lot. I see it, I get here in the morning, I got 3 or 4 errors, I fix them. Okay, I'll do it later, and I forget about it. Multiple different ways to report errors, obviously. Most on this call, if you work for a large major institution, you probably have your own internal mechanisms. Houston Methodist Hospital, we use TAPS, but there's PSN, ISMP, the FDA, consumermedsafety.org, and a number of outlets. Well, let's dive into these barriers a little more in detail, because overcoming these barriers is paramount to us improving the amount of voluntary reporting that we have. And there's certainly been a lot of technology wrapped around this, and things have improved. But fear is the number one problem. You've made an error yourself. Do you fill out this report on yourself, thinking that somebody could come back and sue you, or there could be disciplinary action? Luckily, we've improved these processes to make a very transparent process, a very non-punitive culture. But again, there's news wrapped around, the nurse from Vanderbilt getting charges filed against her, wrapped around medication error. So the fear is still there, and we need to continue to create a safe environment for everyone to continue to report these. Event recognition is probably one of the most overlooked barriers. You have this problem, you think, but you don't fill it out because you're not sure if it was an error. When in doubt, report it and let the experts review it and try and determine, is this an error, is it not? A lot of times we find out, hey, you just spotted a problem within the standard operating procedure or process that's occurring in the institution. There are things that we can improve upon. The time to get these done has always been an issue. Luckily, technology and reporting systems have improved. You're looking at an average 5 minutes to fill it out. Obviously, this is something we never need to lose track of this, because one of the most common complaints other than fear is, hey, it takes too long for me to do this, so I'm not going to do it. Fix and forget, I mentioned this is my biggest crux. I fail at this all the time. This is putting a Band-Aid over a bullet wound. Many times I come in, I see the problem, I fix it, but I don't really fix it. I do put a Band-Aid over a bullet wound. We've got to continue to report these, and we need to do it quickly as possible so that we can learn our lessons and we can drive improvements and help improve the technology as we move forward. Let's talk a little bit about the pain points of medication errors and where they're happening. Well, as most of us know, the practice, they're happening everywhere. They're happening outside the hospital, inside the hospital. As soon as that patient touches the door from time of admission, they leave the ER, they go to the acute care floor, they deteriorate, they go to the ICU. From there, they go to surgery, they come back to the ICU, back to the acute care floor. Now it's time for discharge, the medication reconciliation process. The entire medication use system is full of gaps: poor communication, lack of standardization, lack of integration across the care continuum. And then there's the Swiss cheese model. We've got all these different protective points, but the holes line up and they allow this error to seep all the way through all these defense mechanisms. Latent conditions and active failures align. That's the bottom line around the Swiss cheese model. Transitions in care, as I mentioned that briefly, it's a massive thing. Transitions in care, both on admission, transitioning between floors, and leaving the hospital is a massive area for medication errors as well. The reconciliations are frequently incomplete, done wrong. It's a complex process. Patient access issues whenever they leave the hospital is also a big concern. And if any of you are clinicians like myself and Lumo on the phone, here it's a real problem, the burnout, alert fatigue, burnout. How often are you seeing just these inappropriate alerts that you continue just to click through, and you click through these alerts and it cries wolf and it cries wolf, and finally you get something that's important, but you clicked right through it. It's important to have a system in place that will give you the appropriate information, accurate information that's useful and efficient to your work process. Let's flip back to the patient case. Now we're fast forwarding 48 hours, 2 days. Ketorolac, unfortunately, has been on board this patient, and now we're getting symptoms of significant nausea. The patient is lethargic and has low blood pressure. We look at the labs and we see that the baseline serum creatinine was 1.5. It jumped to 2.5. Our potassium is now up to 5.8. This is a scary moment, an aha moment, where if you're not medical or healthcare related on the phone, this is a very potentially deadly case where the patient could go into sudden cardiac death at any moment. We review it, we see it, now it's too late, the problem's already happened. We're 48 hours into this. We need a system that can detect this and prevent this from even getting to this point. And the identified errors here are not only the prescribed drug, but the dose chosen. And we have a system failure in the fact that we have a lack of an effective clinical decision support tool. So let's start to look at a few more solutions where these solutions are kind of orienting. You've got groups like the WHO who have set forth initiatives, the 2017 initiative, with a goal of a reduction in severe avoidable harm of medications by 50% over a 5-year period. Looking at key areas like high-risk situations, polypharmacy. Again, we've talked about a lot of these transitioning in care, whether coming in or outside the hospital or transitioning in floors. The medication reconciliation process, which has been quite complex for many years, the documentation and labeling as well. Technology is no doubt very much increased and has gotten better. The problem is with new technology, it creates new problems. It wasn't until around 2017 that 100% of hospitals actually had electronic health records. So this is still a very new type of technology. All of us on here know that these electronic health records, Epic, Cerner, others, they've created their own set of problems and haven't really solved much from that perspective. And so we're still dealing with this problem. Electronic medical records, other great technologies like barcoding when it came out, reduced errors by 41%. And now you look at something that's even greater than barcoding, like RFID. RFID has made a massive dent in safety. If you look at companies like IntelliGuard, who have pushed this RFID technology forward, what they've done in that space has been incredible. I encourage you to visit their website and look at how their innovative inventory solutions and their operating machines within the ORs are really changing the game of how we do this, of how we manage this situation. And drug companies like Pfizer are starting to look at RFID technology. Smart IV pumps, Alaris pumps have built-in software. They go off, they alert, guardrails, things like that. Technology has come forth, but again, all technology creates new opportunities to help reduce medication errors. And unfortunately, all technology to this point has really not put a dent in where the errors are actually occurring. ISMP has best practices. The support of clinical decision support tools has really been evolving. We do know that clinical decision support tools offer good things, which I'll talk about shortly, and they have their limitations thus far. Certainly, clinical decision support tools have been great at the point of order entry, allergy checks, dose alerts, drug-drug interactions, things like this. So these solutions continue to evolve and get better. And 95% of hospital leadership do believe that clinical decision support tools are a key moving forward to impact patient safety. So let's take a little bit of look around some of the literature that exists. We do know that when you deploy a clinical decision support tool at the point of order entry and verification, it did make a dent. It has been useful. The problem is that with time, the overwhelming alert fatigue and the override rates have continued to increase. It really pointing out the fact that if you don't have a good system in place that gives you accurate, important information, you're going to start crying wolf, and you're going to start alerting through that. We've had issues of clinician override alerts at a rate of up to 90%, diminishing the overall effectiveness as well. So studies have come out, and there's been a call for action, the need for intelligent alerting systems and customization for each individual institution, because what's going on at our hospital may be different than Ohio State or New York Presbyterian. They have been shown to be cost effective when deployed appropriately. The cost savings is there, reducing avoidable adverse drug events, and if deployed appropriately, they can absolutely improve the workflow efficiency. But what we'll learn is some of that workflow efficiency has been lost. And so when you look at some of the downsides of currently the way clinical decision support tools have been designed and deployed within our health system, if you've used them, they've at times been somewhat of a burden. I've mentioned alert fatigue, but the desensitization is also a real important fact here. If you're not getting a quality, appropriate alert that's relevant to you and your patient and is really specific for your individual patient, then you're going to run the risk of clicking right through it and ignoring it. So it's important to have a system that addresses that. Workflow disruption and inefficiency is massive. It's one of the biggest things that we've looked at our company, Salus, and with our product MAPS, is when they're poorly designed and poorly integrated and poorly implemented, it's not going to be useful. It has to be, we use the word embedded, appropriately within the electronic health record to help you with your efficiency and help you with your workflow. A part of the problem is the current clinical decision support tools tend to stop you in your tracks and prevent you from moving forward. A quality clinical decision support tool should help you move through your patient in a very timely manner and honestly put more time back in your lab to critically evaluate your patient and operate on an expert level. The integration and operability, I've mentioned this a little bit, but also the seamless integration being embedded within the electronic health record is not just for the end user, it's for an IT department within a hospital. There needs to be a system that can be seamlessly uploaded, downloaded, pushed live into production quickly with little to no burden on your IT department. A lot of the clinical decision support tools that exist these days is quite a burden for your integration folks within IT. The data quality and bias, your data needs to be accurate. What you're pulling from the patient's chart needs to be revolutionary, needs to step beyond the norm. It needs to be accurate. It needs to be real-time, truly dynamic. And the information that you're pulling from medical literature, the coded drug information resources that we have, the customization rules need to be accurate, but not just that. The data that you can pull out of this also needs to be important to be able to report that and publish that data and let you know in your institution where your problems are at. At Houston Methodist Hospital, for example, we may have a problem with heparin and bleeding. So we may create a custom rule wrapped around that specifically for them and where their pain points are within that particular problem, wrapped around their policy and procedures as well. There's always ethical and legal concerns wrapped around this. A good clinical decision support tool does not store patient data. It passes information on to the end users. It makes it easy on IT. It's got to be able to get through security checkpoints with your IT team. It's got to be able to get through your legal team as well. And it needs to be very secure. All of these things are incredibly important. And if a clinical decision support tool doesn't address these current needs, then it may struggle within an institution. Well, let's flip back to our patient case real quick. This is a great example of a case early on. We went 48 hours of a drug that shouldn't have been given, at a dose that shouldn't have been given, and a monitoring that should have been done better. 48 hours of this. We didn't catch it in the beginning. It got through that first gate of protection, that Swiss cheese model. Got through it, right? It got through that first hole. The clinical decision support tool beyond that was lacking. It wasn't there, and therefore we couldn't see that this problem was going on. It's paramount that you have a clinical decision support tool that gets you in all layers of this process and can help detect and see the problem occurring and actually prevent the medication error from happening. For so many years, we focused on the medication error happens. I'm going to report it. Now let's fix it so it doesn't happen again. Our system maps, and I'll touch surface based on this, and we'll have future webinars based in more detail about what we do. But our system maps essentially gets all of those pain points, all of those areas where clinical decision support tools must succeed. Our software has been designed to actually focus in on that. Our ease of integration and ease of use. The amount of time it takes to integrate this product is incredibly quick. We lifted it at Houston Methodist Hospital System within 2 hours. We were live in production. The way we are built, the way our software is built, adds to that ease of integration and decreases the burden on your IT team. The ease of use, it takes about 20 minutes to train somebody. You get it in there, they see it, it efficiently works within your workflow. It doesn't stop you from your workflow. It allows you to continue to work on your patient, get your patient seen quicker. You've got the safety mechanism done. You know they're safe. You know things are good. Now you can focus on providing expert level pharmacotherapy plans for your patients. It's completely customizable. We stay up to date with all the literature. We have coded drug information resource, but we also customize based on what our end users need. Again, the pain points at Houston Methodist are not the same pain points at Mount Sinai or Cleveland Clinic. Their pain points are different. We can focus in on where your pain points are at, address those pain points, develop customizable rules, and you've got expert level pharmacotherapists, residency trained clinicians that work for us that design those rules. You come to us and say, we need something for renal replacement therapy. We'll bust that out for you because we know what we're doing wrapped around that, and then we'll work with you. So we can customize it for you, do it for you, and it also takes the burden and the time off your hands to have to do it yourself. Our rules engine is incredibly complex. I've kind of mentioned already a little bit about that. So the customizability, what we do with our alerting system is very unique and state-of-the-art, but we also do lean on and leverage language processing, natural language processing and machine learning, and we are AI capable and ready to go. We use this in a certain domain of really looking at drug disease contraindications. What's fascinating about our product is we do not rely on ICD-10 codes or SNOMED codes. They don't have to be present. Using natural language processing, machine learning, we can accurately get information from the chart without having an ICD-10 code and look at your drug compared to that diagnosis and give an accurate warning about what's going on. For example, a Pixaban in a mechanical mitral valve. A patient may have been on that medication prior for atrial fibrillation. If it's restarted, now they've got a mechanical mitral valve. We pick it up regardless of whether there's an ICD-10 code or SNOMED code there. The data generation and reporting is key. In the literature that's coming out of Houston Methodist is really incredible. So far, we're getting some really amazing stuff. What we do with each institution is, again, we find out what's important to them. Goal-directed medical therapy is important to you. Wrapped around heart failure, we develop data and report generation wrapped around that. Currently, right now, we can do whatever you want. We wrap our current reporting around the types of drug interactions, drug-drug, drug disease, et cetera, the number, the alerts, the time of acknowledgement, who acknowledged it, the data stream within that acknowledgement, what was the dialogue going on, why was it overridden, things like that. We can see medications that were stopped instead of acknowledged. In other words, you have something that popped up. If you stop it, there's pretty much anything that needs to be tracked, we can track. And again, I was saying earlier, that's such an important part of what should be done in an appropriate, strong clinical decision support tool. So in conclusion, when you look at where medication errors in the State of the Union, we have made a dent in what we like to refer to as technical errors. You know, the wrong drug in the wrong bag, patient labeling, tall man letters, changing the names of drugs, the way they're packaged, robotics. I mentioned companies like IntelliGuard, RFID technology. Incredible things have been done, and they have put a dent in the medication errors. But this literature, this novel literature that you're seeing is a call to action saying that this problem has not been solved. And we need this type of smart, forward-thinking clinical decision support tool that improves efficiencies and strength as we move forward to promote the best practice and a culture of safety. Using these powerful tools, we strongly believe are going to catch the medication error before it happens. So what we believe in at Salus is that we want to spot the problem and prevent the error from ever occurring versus going after the fact and saying this error occurred, what could we have done different? And the beautiful thing about our product is we can morph and adapt to you got errors clicking through, we can alter our product to reach those errors and hit those pain points for you. Continuous vigilance, learning, and improvement are absolutely crucial. A good clinical decision support tool will never tell you no. You should never hear that. If you've got a good, well-designed clinical decision support tool and a company that backs that, you come to them with a problem, that problem needs to be solved. We've set our product up to a way where we can solve those problems and continue to adapt to a changing environment. I'll skip through my references quickly here, and I'll get to the last stage here. Kudos to Dr. Luma Sukar and all her work on this innovation. There's our contact information. I'm going to leave everything pulled up. And at this point, Stan, I will turn it back over to you. Thank you all.
Thanks, Brian. That was very enlightening. We're going to now open up for Q&A. Please use the Q&A function in the webinar to ask your questions. We'll sort of let Brian and Luma team tag these questions. The first question we have is what type of clinical decision support tools or technology exists today to help eliminate medication errors?
There are several. Theradoc, MedAware, Vigilance are clinical decision support tools that are out there. I won't speak on their behalf, but I've used Vigilance for 18 or 19 years. The design of these clinical decision support tools is not necessarily set up to take the medication error process and focus in on that. They all have their strengths and weaknesses, and they have their differences in what we do. We differentiate ourselves from the machine learning capabilities, the use of coded drug information resources. The truly dynamic clinical surveillance of what we do is your patient gets better, you're going to know it. Your patient gets worse, you're going to know it. Your patient stays the same, you're going to know it. We are truly dynamic in nature, like a guardian angel. The other clinical surveillance tools have made incredible headway into antimicrobial stewardships, non-formulary management, pain stewardships, being able to manage these things, intervention documentation, things like that. These are the clinical decision support tools that are out there. BPA alerts are out there. For those of us who have used BPA alerts I've used them over a decade, have not offered us any benefit here at Houston Methodist Hospital compared to these other clinical decision support tools that I've even mentioned before. And our clinical decision support tool is far beyond BPA alerts. BPA alerts are a burden. Your staff has to continue to make up and develop these rules. Send them to Epic. Again, it's a snapshot. It'll tell you there's a problem, but it's not dynamic. It doesn't change with the changing condition of your patients. And so this is why the current landscape, medication errors have not been solved, because these pain points that I've mentioned, no clinical decision support tool has yet to address these.
Yeah, that's an important point, Brian. I was taken by your slide on the WHO that had a target of 2022 to reduce errors by 50%, and here we are in 2026, still trying to figure out what the best approach is. Let's see here. We currently use BPAs in our facility to try and prevent medication errors, but they fall short of what we need. What is Houston Methodist using today to detect medication errors beyond BPAs? I know you started to address that, but can you expand on that?
Yeah, absolutely. Great question. We have the same problem with BPAs. It falls short. they're not designed, again, when I go back to that slide, and you think about where the pain points are at, where the clinical decision support tools fail, BPA alerts do not really address any of those issues. What we are currently using at Houston Methodist Hospital is MAPS. So the technology that I presented to you earlier, what we at Salus have developed. Dr. Sakar and I actually developed this while being clinicians. We are still practicing clinicians, so we understand the process. We developed it in the light of where clinical decision support tools have not addressed this problem. Now, again, clinical decision support tools have helped in many other areas. Vigilance, Theradoc, they've done great things, and their literature speaks for itself. But when it comes to medication error reduction, we use this at Houston Methodist Hospital. We've had some incredible results in our first month there, so we are now in month 2, live in production at Houston Methodist, and soon we'll have a media release, and we'll be able to release our data coming up. Very compelling stuff. So to answer your question, to make a long story short, Houston Methodist Hospital system is using MAPS as their preferred clinical decision support tool for medication error detection and prevention.
Yeah, and could you talk a little bit, I mean, you keep mentioning those other surveillance tools, and I think the important differentiator there is that they are surveillance tools. They're in the background watching, whereas MAPS is more front end in real time. And then that drives into this question: what does MAPS look like to a user, such as a prescriber or a pharmacist? How are the issues caught by MAPS communicated to providers?
Great question. You have choices. So with MAPS, again, we're the only clinical decision support tool that's deployed in the way that we're deployed to be available to all disciplines. But you have your choice. It can be available to your pharmacy department. It can be available to your pharmacy and physicians, your pharmacy physicians and nurses as well. At Methodist, they're doing a rollout where clinical pharmacy and pharmacy is going to use it, polish it off, optimize it, and then push it out to the physicians and nurses at the time that it's used. It's strategically embedded within Epic. And although I can't show you an Epic screen for copyright reasons and intellectual property reasons from their perspective, if you think of your screen in Epic, if you use Epic, it's on the sidebar and it's always available to you. And it automatically refreshes as soon as you open that patient. And hundreds of API calls are sent out to multiple different areas and pulls all the drug information literature in. It pulls in all the patient information. Look, we're talking about echocardiograms, progress notes, potassium levels, serum creatinines, blood pressures, you name it. Coded drug information resources, all your customizable rules, pulls into the rules engine, and the colors will change based on a truly dynamic change in your patient. Like Stan mentioned, it's truly dynamic, meaning if your patient gets worse, the color systems will get worse: green, yellow, red, you name it, whatever color systems you choose to use. And as your patient gets better, this is where we truly differentiate. It's going to get better. It's not going to tell you you had a digoxin level from 2 weeks ago and it was 5. At this point, we don't care about that. What you care about is the fact that the digoxin level is now 0.8. So if you've got a system in your hospital, you have to continually go back and document this intervention. Oh my goodness, this dig level was 3 weeks ago. This patient's been home for 2 weeks. Very frustrating. There's no more of that. It truly moves with your patient in the changing dynamic state. So to go back and answer the question more succinctly, it is embedded within Epic. It almost looks like it's a part of it on the sidebar, okay? And currently we're only integrated within Epic. We're moving into the Cerner process here soon. It's available to nurses, physicians, nurse practitioners, PAs, pharmacy department, whoever's involved in pharmacotherapy plans. It's always readily available right there on the side, and a refresh button is there to click through it so you can see it at any time in any tab that you're in there. And your hospital does have the choice to limit it to different end users as needed.
Great. One of our questions is, do you offer sessions that demo this product?
We do, and our contact information is there. You can contact us via email or via our LinkedIn. Would love to and happy to set up a demo. And during this demo, you can see more details about what we talk about. If there are practicing clinical specialists on this webinar, it'll really make sense to you when you see it based on your workflow, how this really ties into the efficiencies in your process. The feedback we've gotten from Houston Methodist has been overwhelmingly positive wrapped around efficiency. What may have taken you 10, 20, 30 minutes to get to a patient will take you minutes from the safety perspective, and then you can focus on optimizing your pharmacotherapy plan. So demos available. We can show you the ease of use, talk to you in more detail about the product, use cases, and really the clinical aspects of it as well.
Another attendee would like to know if the MAPS product is currently available commercially.
It is. The website is there at salusmaps.com. You can visit our website, and we have a link on there to contact us, and there's our contacts there as well. We are commercially available, and so if you're interested and would like a demo, would like to chat with us, we'd love to show you what we got, talk through the process and how we think our process may fit for you. I will say this, currently, we are up for commercialization for Epic users only. However, if there's any Cerner hospitals on the line, please don't hesitate to contact us because we are looking for potential partnerships or collaborations to integrate our product within Cerner. And there may be something we could talk about at getting it into your hospital as a pilot or a testing area as we integrate through Cerner.
Excellent. Brian, can you walk us through how MAPS integrates with existing EHR systems and what kind of training is needed for clinicians to be able to use this effectively?
Good question. Something I mentioned earlier is that I touted the importance of having a clinical decision support tool that is IT proof. You know, we use the word. Now, you're going to talk to your CTOs, and they're going to say there's no such thing. There is no such thing as software that's integrated within hospitals that doesn't require IT lift or burden or problems. We worked with our IT department here to build this product, to make it as easy as possible. I mentioned this, our go live, when we flipped the switch, it took us 2 hours. It's as simple as, think of this like you have an app, you subscribe to it, you pay the money right on your app, and you're in Spotify. We're not quite that quick because we have some legal and security checkpoints to go through, but we did it in 2 hours. It's as simple as subscribing, exchanging URLs with your integration folks. We meet with your Epic Willow team, flip the switch, handle any bugs that pop up, and we go from there. So the integration portion through the IT is paramount. We do not rely on middleware, which just simply means that with most clinical decision support tools, if not all of them, they're going to receive the updates. It has to be downloaded, integrated, and pushed out. You call me with a rule, or Dr. Sukar, our team, and say, we need a rule wrapped around renal replacement therapy, on and off CRRT, HD, whatever. We need something like that. Boom, done. We'll handle the rest. It may take us 2 hours. It may take us 3 days, but we will automatically update that, and it can be available to you like that. Some rules take us 30 minutes. Other rules can take longer, 3 days, 4 days, a week to do. It depends on the complexity of the rule. But most rules can be done quickly and pushed out to you very quickly. As far as training, great question. It took the Houston Methodist Hospital team 20 minutes, 15 minutes a person to train. Honestly, it's so user-friendly that you could probably just open up Epic, click on the Maps tab, look at it, click through a couple things and see it, and really not need much training at all. But it takes about 20 minutes, 15 to 20 minutes to train the staff, and that's something either myself or Dr. Sukar would come on board live, train you all, get everybody using it. Training the end users and nurses is also an important piece to this that we have experience with as well. So training of the staff is actually very simple and very quick.
Well, can you expand a little on the rules engine and talk about how it adapts to changing guidelines and institutional initiatives and priorities over time?
Absolutely. We believe that your rules engine's got to be very smart, no doubt about it. With legacy products, they tend to be a little clunky. we use a coded drug information resource that's constantly validated and verified. We also are expert level trained, residency trained clinicians. We're talking about critical care specialists, cardiology, pulmonary hypertension, ID, internal medicine, you name it, oncology. They work on the rules and the guidelines to maintain a rules database wrapped around guidelines and literature. Also, we work with you. We want to know your pain points. If you come to us, again, I mentioned this, if you've got a problem or you want goal-directed medical therapy to be linked in, and let me use a different example, pain medication. We have the capability of tracking all doses given, pain medication, cumulative dosing. We can put in a rule to say, here's the amount of cumulative dosing, you're getting close. You've reached a threshold, whatever you need wrapped around that, doses given, drugs given, a cumulative dosing. We can run reports historically in patients. There's a number of things that can be done wrapped around within your rules engine to include not just guidelines around heart failure or IDSA, primary literature, but also institutional guidelines. Something we did for Houston Methodist was they were having an issue with warfarin management and INRs jumping too high, above 4. And so they created a policy here that any patient at any time, if the INR jumps by 0.5, 1 to 1.5, 1.8 to 2.6, at any point, if it jumps by 0.5, that dose for that day must be held, bottom line. So we've incorporated that policy and procedure within that rule to incorporate that to alert the end user that this is happening. And so that's another piece of it, of how we stay on top.
Well, thank you. I think we've got maybe 3 minutes. Maybe you could quickly just answer what are the primary barriers to integrating MAPS into a large health system?
There's multiple areas. First, the security checkpoints are pretty easy for it. We've been through full security. We've been through FDA 513G, this process of validation, verification. Getting it into a hospital system requires, if you've never seen the movie Never Ending Story and the Sphinx gates where there's a couple of gates you got to go through. One is Security Council, of course, and your IT and your pharmacy informatics. We have quite a bit of experience getting through that. Whoever's budget this falls underneath, let's say it's the Department of Pharmacy, the director wants it, the staff wants it, it gets through Security Council, then we go to your CFO and we work with your CFO. So the barriers are more about getting through these gates versus the integration process and the actual use of the product. Dr. Sukar and I have an extensive amount of experience working with these individual leaders within hospitals to help you get that through the process. A lot of the times you may get communication, well, how do we get it through Security Council? Feel free to contact us and we'd be able to help you with that. So the main barriers tend to be getting through these gates for any clinical decision support tool versus the actual integration and the use of the product.
Yeah, we've got a couple of more questions, but I think we're at time. So we'll answer these questions offline. With that, I thank everyone for attending. We will be having a follow-on webinars. As Brian said, they're in the process of studying this technology at Houston Methodist, and are going to be excited in sharing both process and outcomes data with you in the near future. With that, I thank you and have a good rest of your day.
Thank you all.